afternoon, everyone, and welcome to today's PHO Rounds presentation on pediatric nutrition and feeding guidelines. My name is Sarah Orr, and I'm an applied public health science specialist here at PHO, and I have the pleasure of moderating today's session. I would like to begin by acknowledging the land from which I am speaking. I join you today as a settler born on the traditional territories of many nations. I am located in what is now known as Toronto, a city that takes its name from the Mohawk word takaranto, meaning where there are trees standing in the water. This place is the treaty lands and historic homeland of the Anishinaabe and Haudenosaunee Confederacy and the Wendat, with the Mississaugas of the Credit First Nation being the current treaty holders. I also wish to acknowledge that we are all joining this virtual space from across Ontario and beyond, connecting from many different traditional territories of diverse First Nations, Inuit, and Métis people. My work in public health is part of my commitment to this land, a commitment to addressing colonial harms, as I am on a journey to learn the specific actions that I can take to be a better steward in relationship with Indigenous communities. And it's now my pleasure to introduce the speakers for today's presentation. Paula Ross is a registered dietitian with over 10 years of experience in public health. Paula currently serves as chair of the Ontario Dietitians in Public Health Family Health Nutrition Advisory Group, where she leads initiatives to promote healthy growth, infant feeding, and family well-being. Laura Atkinson has been a registered dietitian for over 27 years, with 23 in public health, focusing on infant and young child feeding. With extensive experience in resource development, Laura has been involved in pediatric nutrition guidelines since their inception and values the importance of practical, supportive, and consistent feeding messaging to help parents raise competent eaters. And now I will pass it over to Paula.
Thank you, Sarah. So just to begin with today, this presentation is intended for educational purposes only. It's not a substitute for individualized clinical assessment or professional judgment. The tool that we will be discussing today was developed by registered dietitians, drawing on the most current evidence and best practices in nutrition care. It's designed to support interprofessional collaboration and to enhance nutritional assessment, but should always be adapted to reflect the specific context and needs of individual patients. You're encouraged to apply your own expertise and consult relevant guidelines, standards, and organizational policies when implementing this tool in practice. Throughout this presentation, the terms patients and clients are used interchangeably to reflect the diverse settings in which care is provided. We recognize that individuals of all sexes, gender identities, and expressions may be involved in feeding their baby or child. The term parent is used broadly to refer to any parent or caregiver engaged in the child's care. Additionally, while terms like breast milk, breastfeeding, and breastfed are commonly used, we acknowledge and respect that terms such as human milk, chest feeding, chest fed, lactating, expressing, or pumping may be used based on individual preference and context. Laura and I are representing Ontario Dietitians in Public Health, and we have no conflicts of interest to disclose. No commercial support or sponsorship was received for the development of the pediatric nutrition guidelines or the delivery of this presentation. So you might be wondering, who exactly are Ontario public health dietitians and what do they do? Public health dietitians work in local public health units across the province, and we're all connected through a professional organization called Ontario Dietitians in Public Health, which we refer to as ODPH throughout this presentation. As registered dietitians in public health, our role is really about championing health through food and nutrition at a population level by focusing on prevention, equity, and creating supportive nutrition environments. As a group, ODPH provides leadership in public health nutrition, and we support collaboration amongst members to help meet the Ontario public health standards. We also bring nutrition-related priorities forward at the provincial level. ODPH is an affiliate of ALPHA, the Association of Local Public Health Agencies. This connection means we can help shape conversations and decisions on broader public health priorities, with nutrition as part of that bigger picture. We've worked on several initiatives with partners like the Ministry of Education, Health Nexus, and Public Health Ontario, developing tools and strategies that many of you might use in your practice today. So, overall, public health dietitians bring a nutrition lens to public health work, and ODPH helps us stay connected, consistent, and informed as we work alongside of all of you in the broader healthcare system. Before we move on, we want to take a moment to acknowledge the many people who've contributed to the development of the Pediatric Nutrition Guidelines, which I'll refer to as the P&G throughout the presentation. The very first version of the P&G was created back in 2003 in response to a clear need, making sure public health and primary care providers were giving families consistent nutrition messages. Since then, the guidelines have been updated regularly over the past 22 years to reflect evolving evidence and best practices. They've even been used to help inform other important tools like the Rourke baby record and have been adapted with permission by other health authorities, including the BC Ministry of Health and the BC Centre for Disease Control. A huge thank you goes out to the ODPH Family Health Nutrition Advisory Group for their leadership and ongoing support throughout the years. We're also incredibly grateful to the many physicians, nurses, lactation consultants, and dietitians from both public health and clinical settings who took the time to review and provide feedback. Their expertise and insights help shape this into the comprehensive, practical resource that it is today. So, before we dive in, let's take a moment to look at today's learning objectives. So, we're going to start off by describing the purpose, scope, and key components of the P&G. Then we will identify evidence-based nutrition recommendations, developmental feeding milestones, and indicators of nutrition risk across different age groups. We will recognize strategies to support responsive feeding, address common nutrition challenges, and tailor recommendations based on the family and their individual circumstances. Last, we'll explore how to apply the P&G in practice and provide consistent evidence-based guidance. What exactly are nutrition guidelines, or P&G for short? At their core, they're a credible evidence-based resource that outlines nutrition and feeding guidance for healthy full-term infants and children up to 6 years old. They also help identify potential risk factors, what we often call red flags, that may signal when a child might need extra support or further assessment. The purpose of the P&G is pretty straightforward. It's meant to support you as a health professional in providing high quality, consistent feeding advice and to help recognize when a child might be at nutritional risk. It's available in both English and French on the ODPH website at odph.ca/PNG for health professionals. The pediatric nutrition guidelines are meant for a wide range of health professionals who work with young children and families. That can include physicians, nurse practitioners, and registered dietitians, but also a number of other roles like registered nurses, lactation consultants, speech language pathologists, and occupational therapists. Really, anyone who supports child development, feeding, or family health, whether in primary care, public health, or community health settings, can use these guidelines. The idea is to make sure that we're all on the same page and providing consistent, evidence based advice to families, no matter who they're talking to. You might be wondering how the pediatric nutrition guidelines were developed. In short, the answer is with a strong foundation of high quality evidence and a lot of collaboration across disciplines. The content is informed by a wide range of trusted professional sources, including guidelines from Health Canada, the Canadian Pediatric Society, the American Academy of Pediatrics, and Dietitians of Canada. On top of that, the team drew from robust, peer-reviewed research to make sure the recommendations are current and backed by science. One thing we really want to highlight is that the P&G is fully referenced throughout. So if you're ever curious about where a recommendation comes from, it's easy to trace it back to the original source. As I mentioned earlier in the acknowledgements, every edition of the P&G has gone through an extensive external review process. That included feedback from a wide mix of professionals. This helped to ensure that the guidelines are both relevant and practical across different roles and work environments. The 2025 edition includes some exciting updates. It has an improved design for easier reading, better web accessibility, a broader range of topics, and more inclusive language to reflect the diverse families that we all work with. Overall, these updates aim to make the PNG even more useful and accessible no matter what setting you're in. Now that you have an understanding of who this tool was designed for and the rigor that has gone into its development, I want to spend a little bit of time focusing on why you should be using the PNG in your day-to-day work. Simply put, the PNG help all of us speak the same language when it comes to feeding and nutrition for young children. Families often hear advice from many different sources: public health, primary care, early years programming, online, and social media. When health professionals are aligned and using the same evidence based, consistent guidance, it helps build trust and reduces confusion for parents. That's a big part of what the PNG offers, a way to standardize the messages across disciplines. The guidelines can also help to catch nutrition concerns early, whether it's at a well baby visit, a home visit, or a community check in. The PNG can guide those everyday conversations about things like introducing solids or selective eating, and can help to identify when a child might be at nutritional risk or when a referral might be needed. These guidelines can enhance your efforts to educate and empower parents and caregivers while supporting the delivery of consistent, proactive care. Now that we've looked at why the PNG is valuable, let's move into how it can be used in your practice, no matter what role you play on the care team. As previously mentioned, the guidelines are designed to support clinical decision making and are really helpful for guiding conversations with parents and caregivers. The PNG provides clear, evidence based information on topics like age appropriate feeding milestones, introducing solids, responsive feeding, and the division of responsibility. The PNG also touches on special considerations like vegetarian or vegan diets, selecting plant based beverages, and how to screen for and address food insecurity. Depending on how you document in your practice, it might be worth considering how the PNG could be integrated into your EMR to support more consistent charting, whether that's tracking milestones, noting nutrition advice, red flags, or recording referrals. For example, this could involve working with your EMR vendor to build a template that lists age appropriate feeding milestones or red flags on a patient's chart that can be easily checked off. This allows you to quickly see where a child falls in terms of nutritional risk. This kind of integration can help ensure everyone on the care team is on the same page and can also support broader organizational uptake. When all providers are aligned, families receive consistent, evidence based messages about feeding and nutrition, no matter who they're seeing. That kind of consistency builds trust and can lead to better outcomes for kids. The recommendations are organized by age groups to align with feeding recommendations and developmental milestones. This allows for ease of use during appointments. This is an example of the layout that you will find within the document when you download it. Each section is color coded for quick identification of milestones, guidelines, and red flags. If you're viewing the guidelines directly on the website rather than downloading the document, the sections will appear in this format. You can use the table of contents on the right-hand side to quickly navigate to any section you're interested in. In addition to the milestones, guidelines, and red flags based on age, the PNG provides information on key nutrition topics that can be identified with a gray heading. Some of these topics include promoting breastfeeding, infant formula, growth monitoring, vitamin D and iron, and family meal times, just to name a few. And now I'll head it over to Laura.
Great, thanks, Paula. What we'd like to do next is take some time to highlight some of the enhanced messaging featured in the updated PNG. We'll be exploring key topics such as promoting and supporting breastfeeding, introducing common food allergens, helping parents navigate food textures, self-feeding, and baby-led weaning, understanding responsive feeding, what it means, and how we can foster a positive, nurturing feeding environment, and addressing household food insecurity and identifying actions health professionals can take to support families. Let's start with the promotion of breastfeeding. As health professionals, we all play an important role in helping parents making informed feeding decisions. That means providing unbiased, evidence-based information without judgment so families can choose what works best for them. A key period for this is during pregnancy. Research shows that most families make their infant feeding decisions well before baby arrives. So for anyone working with prenatal clients, whether that's during checkups or prenatal classes, those conversations about feeding options are invaluable. When we're educating parents about breastfeeding, talk about milk supply in the early days after birth. Parents may worry their baby isn't getting enough, especially if they only see small amounts of colostrum or aren't aware of early breast milk production. Helping them to understand that what they are producing is exactly what their newborn needs can make a big difference to protecting breastfeeding and may prevent unnecessary infant formula supplementation. We also want to make sure families know where to go for help, including supports in the areas they live in. That might be public health programs, including home visiting nurses and in-person or virtual breastfeeding supports, hospital outpatient breastfeeding clinics, or 24-hour phone and e-chat options like Health 811. Having those connections ready can reassure new parents that there are services out there when they need support. And finally, it's important we all keep building our knowledge and confidence in supporting breastfeeding. The breastfeeding protocols for healthcare providers are a great resource. They were developed to help guide professional best practices and are available on the Toronto Public Health website. You can also check in with your local public health unit. Many offer training or updates for health professionals who want to strengthen their breastfeeding support skills. Now let's talk about introducing common food allergens. This is an area where guidance has evolved a bit over the years, so it's helpful for all professionals to be on the same page. For babies at high risk for developing food allergies, introduction is at around 6 months of age, but not before 4 months of age. And for babies at low risk for developing food allergies, it is at around 6 months of age, which is a general guidance for when to start complementary foods. Now, what does around 6 months mean? It's not a hard and fast age. What really matters is developmental readiness. So we're looking for signs like good head and neck control, the ability to sit up alone or with minimal support, and being able to grasp objects and bring them to their mouth. These are key signs that a baby is ready to start complementary foods, including allergenic foods. When introducing common food allergens, the approach is still to offer one at a time in a safe texture for the baby's age and stage. That hasn't changed. What has changed is the timing between introducing new common food allergens. We now know that it is okay to offer new common food allergens on consecutive days. So there's no need to wait 2 or 3 days between introducing each new common food allergen. Also, once a common food allergen has been introduced without any sign of a reaction, it's important to keep offering it regularly, ideally weekly, to help maintain tolerance. So overall, early introduction, meaning without any unnecessary delay, with ongoing regular exposure, is key to supporting tolerance, whether the baby is at high or low risk for developing food allergies. Next, let's talk about food textures, self-feeding, and baby-led weaning, topics that come up a lot when supporting clients with starting complementary foods. It's important to highlight that parents do not need to follow a staged approach to advancing food textures. Following a sequential progression from textures, from lumpy to minced, then solid textures to pieces, are not required. This guidance is well established. According to Health Canada's 2014 Nutrition for Healthy Term Infants, babies who have signs of readiness for complementary foods can be offered a variety of textures right from the start. You can also remind parents there is no need for special baby food making equipment. Parents can simply offer modified family foods using basic kitchen tools. Whether or not families use the term baby-led weaning, which by the way does not have a standard definition, the idea is to support babies to self-feed in ways that work for them. And this could mean a mix of spoon feeding and finger feeding, which is totally fine. There are options to encourage and build those self-feeding skills. For example, strips of soft food work well for babies who don't yet have the pincer grasp using the palmar grasp. They can grab and hold the food or the strips of food using their whole hand and take bites from the food. Another option to consider, especially when a parent is doing baby-led weaning with strips of food and says their baby isn't taking any bites off, is consider offering smaller pieces of soft food, about the size of a chickpea or blueberry. Babies can paw or rake up the food with their hand, curling their fingers around the food, and then bring the food to their mouth, almost scraping or pushing the food into the mouth. These small pieces are big enough for babies to paw or rake up, but not so big that they become a choking hazard. Soon after, they will develop the pincer grasp and self-feed with their fingers. For families who are doing spoon feeding, we can suggest the hand-over-hand method, using an infant utensil that has a short, thick, and rounded handle that babies can hold in the palms of their hand. The parent then guides the baby's hand and use the spoon. Lastly, we want to gently encourage parents to avoid those highly processed baby and toddler snacks like rice rusks or puffs. While they are popular and often marketed as early finger foods, they don't offer much nutritionally and can displace nutritious modified table foods. They also don't support self-feeding skills any better than soft cut-up table foods. So overall, we want to support flexibility and confidence in parents, helping them understand that there are many safe and appropriate ways to offer solid foods and build feeding skills without needing to rely on commercial products or follow a rigid texture timeline. Let's move into the concept of responsive feeding, which is more than paying attention to hunger and fullness cues, although that's certainly a part of it. Responsive feeding is about supporting babies and young children to develop self-regulated, autonomous eating while also nurturing their cognitive, emotional, and social growth. It's about food and relationships, learning, and brain development. It's not only about responding to those cues, but also about creating an environment that encourages self-feeding, positive interactions, and a sense of safety. One of the big ideas here is that feeding is a shared responsibility between the parent and the child. And for many parents, this can be a real mindset shift. They often assume that all the control should sit with them. So, part of our role is helping them to understand and feel confident with what their role is and what belongs to their child. Here's a breakdown of how the shared responsibility evolves over time. From birth to 6 months, the parents decide what milk is offered, and the baby decides when, where, and how much to eat. A great example of this is on-demand breastfeeding. The parent offers, but the baby leads the feeding. From 6 to 12 months, the parent continues to decide what is offered and begins to shape when and where feedings happen. The baby still decides how much to eat and whether they want to eat at all. Think about a baby who's breastfeeding on demand, but also being offered solid foods in a high chair a few times a day, maybe before or after breastfeeding, depending on the baby's cues and routine. From 12 months and beyond, the parent takes full responsibility for what, where, and when feedings happen. The child decides how much to eat or if they will eat at all. An example here would be a predictable daily routine with meals and snacks offered a few hours apart at the table and free from distractions like screens or toys, essentially avoiding grazing on food and milk throughout the day. When parents honor these roles, it builds trust and respect at meal times and helps children grow into competent eaters who listen to their own cues, which is a key lifelong skill. So for us as interdisciplinary health professionals, the takeaway is that responsive feeding is a developmental approach, not just a nutrition strategy, something we can all reinforce in our work with families. Let's now focus on how we can help parents create that positive and nurturing environment for feeding. This really builds on the principles of responsive feeding. Remind parents that when there is no pressure or forced feeding, healthy babies and children are able to self-regulate their intake. Fluctuations in intake are normal and are to be expected and will no doubt vary from day to day and even from feed to feed. Sometimes, when parents see their child eating what they perceive as too little or refusing certain foods, it can be tempting for them to apply a bit of pressure, either with words or actions. But we know from research that pressuring children to eat, whether using positive or negative pressure, doesn't actually help in the long run. It might get the child to have a few more bites at that particular meal, but often leads to picky eating, mealtime stress, and negative attitudes around food. We often think of pressure as being negative, like scolding or pleading or saying things like, just one more bite, or you have to finish your plate. But positive pressure can be just as problematic. This includes things like praise, bribes, or rewards. For example, if you eat your broccoli, you can have a cookie, or good job, you ate it all. While well-intentioned, these strategies can make food feel like a test or create power struggles. Basically, if a parent is trying to get their child to eat something, whether it's with encouragement, rewards, or pressure, it's likely not a responsive approach to feeding. It's also worth thinking about how we as health professionals talk to parents about food and growth. If we unintentionally make a parent feel like their child needs to eat more or grow faster, they may start to feel anxious and override their child's cues, undermining that shared responsibility model we just talked about. Another helpful tip we can share is to use food neutral language. That means calling a cookie, not a treat or junk food. Those kinds of labels tend to moralize food and can make certain foods more desirable or special. Instead, we can encourage parents to use language that's simple and descriptive, like talking about the color, temperature, shape, or texture of the food. This kind of age-appropriate food talk helps children engage with food without attaching value to it. Also, young children do not have the cognition to understand health implications of food. So telling a young child a food is healthy for them is meaningless to the child. And lastly, encourage families to eat together as often as they can. Family mealtimes are powerful. When parents model eating a variety of foods, it has a significant influence. Even if the child isn't eating much, just sitting there together and sharing that experience matters. And while the food may need to be modified in texture for the child, ideally, they are being offered the same food as the rest of the family. So in summary, low pressure, food neutral, responsive interactions create not just better meal times, but healthier, happier eaters over time. We're going to wrap up our highlights today by talking about household food insecurity. When we say household food insecurity, we're referring to the inadequate or insecure access to food due to financial constraints. It's not about the lack of food in a community, and it's about not having enough money to buy food. almost 1 in 4 households in Ontario are affected by food insecurity. So this is a widespread issue. For young children, the effects of food insecurity go far beyond hunger. It's associated with mental health challenges like anxiety, depression, and low self esteem, as well as hyperactivity and inattention. It's also associated with poor general health, including higher risk of nutritional deficiencies, impacting healthy growth, development, and learning. And it's linked to adverse childhood experiences, often called ACEs, which can affect brain development, resilience, and long term well being. What's important to highlight here is that food-based responses like food banks or donations are an immediate short-term response to address hunger and not a solution to food insecurity because they don't address a root cause, which is lack of income. If a family is experiencing food insecurity, they're very likely struggling with other essentials too, like rent, medication, transit, clothing, or just staying connected through phone or internet. So food is just one part of a much bigger picture. In short, to truly reduce household food insecurity, we need to support solutions that address income because that's where the real change happens. Now that we've talked about what household food insecurity is and how it impacts young children, let's shift to what we can do about it in our roles. There are several actions for health professionals to take. And the first one is simple but powerful: screen for poverty. You can use a practical tool called Poverty, a clinical tool for primary care providers developed by the Center for Effective Practice. It helps start conversations about financial strain in a respectful, evidence informed way. And if you're in primary care, it can be built into some EMRs. Next, when it comes to completing forms for things like Ontario Work Special Diet Allowance, which includes allowances for pregnancy and breastfeeding, consider not charging clients. For families already under financial stress, even small fees can be a barrier. Another big support is helping clients access the financial benefits they're already entitled to, but often require a filed tax return. Many families miss out on benefits simply because they haven't filed their taxes. You can connect them to free community tax clinics, which are available across Ontario. You can also direct families to 211ontario.ca or suggest they call 211. This service connects people to local resources, including emergency food programs, housing supports, parenting services, employment help, and more. It's available 24/7 and can really help families navigate what's available in their area. And finally, when you can, use your voice to advocate for income-based solutions. Whether it's through your organization, networks, or community involvement, speaking up about the need for adequate income supports is an effective way to address the root cause of food insecurity. If you're looking for more information and a better understanding of why food programs are not the solution, check out the ODPH Food Insecurity webpage. So while we can't solve poverty on our own, there are opportunities to make a difference, both directly with families and by advocating for broader change. Thanks, and I'll pass it back to Paula now.
Thanks, Laura. So, when it comes to supporting families with early feeding, registered dietitians really play a key role in bridging research with real life parenting. We all know that there's a lot of information out there, new studies, evolving guidelines, social media advice, and it can be overwhelming for families. Dietitians help translate the science into clear, practical guidance that actually fits into the day to day routines of parents and caregivers. For example, we take the latest on topics like early allergen introduction or responsive feeding and turn it into doable, parent friendly steps. What's also really important is that nutrition advice isn't one size fits all. Families come with different cultural traditions, feeding values, and lived experiences. Dietitians are trained to offer individualized, culturally respectful support, which not only makes families feel heard and included, but also helps to ensure that the guidance we give is realistic, meaningful, and more likely to be followed. Another big piece is that feeding isn't just about food, it's about relationships. Dietitians help promote responsive feeding by supporting parents to understand and respond to their child's hunger and fullness cues. We also work to create positive mealtime experiences, which can make a big difference in helping kids feel confident around food and open to trying a variety of new foods, especially in those early years when food acceptance is developing. And of course, dietitians don't work in isolation. We're all about collaboration, whether it's with physicians, nurses, educators, early childhood staff, or community programs. We aim to keep public health messaging consistent, evidence based, and family centered. And when needed, we also advocate for policies that support food access, responsive feeding environments, and culturally inclusive nutrition supports. So at the end of the day, dietitians are more than just the food people. We're your partners in health promotion, prevention, and family support, helping to build confidence in parents and consistency across the care team. Next, I'd like to direct your attention to the ODPH prenatal and infant nutrition page of our website. This is a great hub for up to date, evidence informed resources you can use in your work with families. On this page, you'll find the Pediatric Nutrition Guidelines, as well as two other key client resources developed by ODPH. The first is Eating Well During Pregnancy. This resource walks through the current recommendations for prenatal nutrition in a way that's supportive, food neutral, and weight neutral. It also includes some helpful information on making infant feeding decisions and nutrition topics like breastfeeding. So it bridges both prenatal and early postnatal topics. The second resource is Feeding Your Baby, which offers a comprehensive overview of introducing solid foods during the first year of life. And there's a bit of good news. An updated 2025 version is almost ready to go and should be posted within the next month or two. All of these resources are available in both English and French, making them accessible for diverse families across the province. We really encourage everyone, no matter your role, to use these tools in your practice. They help ensure that families are receiving consistent, current, and supportive messages about prenatal and infant nutrition. Before we wrap up, I just want to highlight a few other resources available through the ODPH website that might be useful to you in your work. As mentioned earlier, we have an excellent food insecurity page. One key document there is the Provincial Report on Food Insecurity and Food Affordability in Ontario, which was developed in collaboration with Public Health Ontario. It gives a comprehensive picture of food affordability across the province, which is really helpful for understanding the broader context behind the challenges families face. You'll also find our position statement and recommendations on responses to food insecurity. This document emphasizes the need to move away from food charity as the main solution and instead focus on public policies that improve income security for vulnerable households. It's a great resource to reference when advocating for systemic change. Another area that ODPH has done a lot of work in is weight inclusive approaches. On that page, you'll find the position statement towards a weight inclusive approach in public health. It raises awareness about the harms caused by weight bias, stigma, and discrimination, and offers practical recommendations for creating more inclusive, supportive environments. We also have tools designed to help health professionals apply these principles in practice, like healthcare without harm, supporting patients in weight inclusive care, and a weight inclusivity checklist that organizations can use to reflect on their own policies and environments and messaging. And finally, the ODPH website includes a range of other topic areas like food literacy, food systems, and Indigenous foodways. So there's a lot there to explore depending on your area of practice. I encourage everyone to take a look when you have a chance. These are great resources to help ensure our work across disciplines is consistent and equity focused. So I think we will now pass it back to Sarah for any questions that you might have in today's presentation. If you have any questions and you'd like to connect with ODPH, please connect with us at info@odph.ca. Thank you.
Thank you, Paula and Laura. First off, that was a great presentation and really gave a good introduction for everybody to the guidelines from ODPH, which are obviously a really great tool. We're now going to move into the Q&A segment to answer questions from our audience. And so a quick reminder to everybody, if you haven't already, please enter your questions into the Q&A pod. And it's good, we have some to start off with. It looks like the first bunch are really focused on allergens. So two folks ask in different ways if a baby is supplemented with formula in the early days, should they continue to be introduced to milk protein, for example, a small amount of protein, until they are ready to transition to milk at an older age?
I'm happy to speak to that. Certainly there is the CPS dietary exposures and allergy prevention, the position statement. So their recommendation within that CPS statement does recommend around 10 millimeters of infant formula to continue to be exposed just in hopes for the prevention of milk allergy. Now, you might notice that it is not included in the pediatric nutrition guidelines this round. Certainly since that statement came out by CPS, there has been research since then. There's a SPADE study and the COMEAT study that certainly support that prevention approach. So perhaps in our next version of it, there may be some information on it. I would advise to also look at the information that Food Allergy Canada has on their website. They have fantastic information with regards to how to introduce common food allergens. They have webinars on milk allergy development and potential prevention. So yeah, so it's certainly an approach to take, but we have not included in this particular version of the PNG.
Okay.
And yeah, Paula, if you'd like to add anything to that.
That was exactly what I was going to suggest.
Okay, yeah, because that question was also asked by a physician who asked if they should be advising the parents to give their baby formula daily in keeping with those guidelines, but you've recommended that they seek some more information.
Well, it is also on, if you look at Food Allergy Canada, they have a resource, Eat Early, Eat Often, and it is in there recommended to maintain introduction to cow's milk if it's been offered through formula, as little as Laura said is 10 milliliters daily to maintain that tolerance.
Okay. More allergy-focused questions. So regarding the introduction of allergenic foods, do you have any recommendations on when to reintroduce the amount, etc., in the cases of mild and moderate allergic reactions? So if a baby has had a reaction, but it's mild, when do you reintroduce?
Yeah, certainly if there's any suspected reaction, we would certainly advise to connect with their primary care provider and to follow up with that. And you know, one of the things with the PNG, it's not an all-encompassing document on how to treat all pediatric conditions. So it does provide advice as far as introducing the common food allergens, but we would certainly defer to the individualized recommendations from the primary care provider.
Okay, maybe this one will be asked or answered in a similar way, but it was another question. I've had parents ask if they should have Benadryl on hand when introducing allergens.
I would say again, refer to the individual's healthcare provider, and I would recommend that they look at healthcare provider guidance documents. So our PNG is not really focused on that level. It's more about the introduction of solids, but that's more of a pediatric allergist question.
Okay.
And anecdotally, in presentations, there's been the advice not to count on that as a tool to use and rely on.
Yeah. And as Laura had mentioned on the Food Allergy Canada website, there are several webinars, and there is a section for healthcare providers. So if you are a healthcare provider seeking more information or guidance around things like that, that would be my first recommendation to check that out and see what advice they have for your practice.
Great. This one is more about the development of the guidelines. So this person's curious about the diversity of the team that developed the guidelines. And the question comes from noticing how Western or Westernized strategies play a dominant role. And in practice, they find it challenging to base recommendations on such resources to families from other backgrounds. So if you could just speak to that a bit.
Yeah, so as I mentioned in the presentation, the team who developed it was led by the Ontario Dietitians in Public Health, and we did that in consultation with a variety of other disciplines. So our evidence comes from the guidelines from Health Canada, from the Canadian Pediatric Society, from the American Academy of Pediatrics, and as well as Dietitians of Canada. And then we had different healthcare professionals review and provide feedback to us to ensure that it was not it was evidence-based, but that it would fit and be practical for many different types of healthcare providers. And so in our pediatric nutrition guidelines, we do give advice or some guidance on how to adapt the PNG based on different cultural situations so that it can be applicable to a diverse range of individuals. I don't know, Laura, if you have anything else to
Yeah,
add.
no, I think you've covered. Yeah.
Um, Back to allergens. How do you introduce food allergens in a practical way?
I'm not really sure what is meant by practical way. There's certainly safe ways to offer the common food allergens. So, for example, with peanuts, we certainly wouldn't be giving a baby a whole peanut. So there are safe ways to offer peanuts, whether you take a little bit of warm water and mix it in with some peanut butter just to kind of dilute it a little bit, because certainly peanut butter straight up would be too sticky and could be a choking hazard. And there's certainly products in the store that you can buy now, peanut products. I would just, like Paula mentioned, the Eat Early, Eat Often resource by Food Allergy Canada has a really great, that resource literally goes through some of the common food allergens and specifically different ways to prepare and offer those foods. So that would be sort of one example of one that when you would give it you know, as like a whole peanut, it wouldn't be appropriate. So there definitely are ways. It's really looking at really modifying that food to a texture that is safe for a baby.
Yeah, and I think as Laura mentioned in the presentation, really to make it practical is just making sure that the baby is developmentally ready to have the introduction of solids or complementary foods, and then that's the appropriate time to start working on introducing some of the common allergens.
And I think that's one of the challenges, I think, anecdotally, we've been sort of having is sometimes babies will start solid foods before their signs of readiness. And so baby is, on an incline, they're very passive with their feeding. It doesn't necessarily start feeding off on the right foot. So quite often they won't be ready. So you're really looking at just like really a thin puree that would kind of almost need to just kind of be poured in, small amounts on a spoon. So when we wait for babies to be ready for solid foods, it really opens up the option as far as how we can offer. So, a baby that's ready can have, a piece of egg as opposed to necessarily pureed thin on a spoon when they're not ready for solid foods yet. Mm-hmm.
Great, thank you. The next question is on food insecurity, which you guys highlighted in a really great way through your presentation. I also want to throw in that it's 1 in 4 households in Ontario that are food insecure, but it's actually 1 in 3 children at last measure. So this is something that is certainly a context for folks working across the province with families with children. But anyway, this question for families with food insecurity and or poor eating habits, and they don't qualify what that is. Would you recommend continuing use of formula beyond 12 months to supplement nutrition if they're not eating a variety of iron-rich foods, etc.? I find families want to move to homogenized milk right away to reduce cost, but there's a worry that they're not getting enough nutrients from foods.
Yeah, and I'd say that's really a tricky one, and it really has to depend on the nutritional risk profile of that child and really doing a full nutrition assessment to get a better understanding of what foods are being consumed. And then really having that detailed conversation with the family to better understand what their challenges are around food security to determine if that is an appropriate strategy for them or not.
Yeah. And I would add, it's not typical for formula to be required or needed beyond 12 months. And
Right.
certainly formula is expensive and it just keeps getting more expensive. So yeah, we want to be really mindful of not necessarily encouraging continuation of infant formula beyond the point that it's necessary. And, I think the question might have highlighted iron. Certainly there are cost-effective options for iron that might include some of the plant-based proteins, and even utilizing infant cereal, perhaps in creative ways in the sense that you can use it in a lot of recipes. There's lots of recipes online where it could just be mixed in if that's a particular nutrient of concern. But yeah, we'd certainly need to be mindful of, making recommendations that our clients can't really do because of the financial constraints about that, and formula certainly is a big one.
The other thing that I was just thinking about that question, and I'm not sure if this is what the individual was getting at, but you also want to make sure that if they do continue on the formula, that it's not delaying the progression of the introduction of solids or
Mhm.
complementary foods, because just because the child isn't eating well, so then you say, oh, well, we'll give them formula to ensure that they're continuing to at least get the nutrient needs, but then they delay the introduction of complementary foods, and then they don't have the opportunity to develop their, oral motor skills, and then that can lead to a whole host of problems down the road itself and feeding challenges down the road. So also to be mindful of that, you really want to make sure that they don't delay the introduction of complementary foods for developmental purposes as well.
Yeah, and really transitioning into that toddler feeding routine. So the question I think had mentioned sort of like beyond 12 months. I mean, things really change when they hit 12 months. And we have information within the PNG that really speaks to routine development and, kind of tips around sort of selective or picky eating. Certainly when toddlers, since they turn toddlers when they're 12 months old, toddlers that drink too much milk, it's certainly going to impact their solid food intake. The timing of when solid foods are offered, right? They need a break to become hungry. Sometimes, 12, 13 months of age, parent might be giving formula right when they wake up and then, right after dinner. And well, then that's really setting up the toddler at that point to not really have an appetite at the meal, because either they just had some and they're full, or if they like it, especially if it's still offered by a bottle, because we do encourage transition to cup by 12 months, that if they know that's going to come, then they're less motivated to eat if they know they're going to be getting something else after. So we've got a lot of really good tips in there around in the pediatric guideline around that transitioning into a toddler routine. And then certainly if there's challenges, there is health one that has dietitians. Check with your local public health unit. A lot of health units provide or have the option to connect with a dietitian for free. And then certainly if someone has private insurance, then there's always the option then to have a private dietitian to really get into things a little bit more in detail.
Okay, we're at 12:58. I'm going to try to sneak in one more question. This one says the PNG touches upon sugar substitutes. What are the guidelines for sugar?
Well, as far as sugar substitutes, it's not something we certainly recommend. There's certainly ones that are considered to be safe. The challenge is that any product that is going to have a sweetening substitute in it, quite often those are foods that not necessarily are going to be the highest quality foods. So that's something to be mindful. And, certainly sometimes there's yogurts out there and things like that that are starting to add sweeteners into their products to help lower the nutrient profile, let's say calories for the adults. That might be, they're adding these things in there to advertise. Then, really generally, we're encouraging to just offer just regular yogurt, always mix fruit in there. But it's not something we actively, recommend, but there's certainly ones that are considered to be safe.
Okay. Well, thank you both so much for the presentation and answering all those questions. And as we wrap up today's PHO round session, yeah, I just want to thank you guys again. I also want to thank everybody who's joined us on the line for today's event and for those of you who sent in questions. You can expect a brief survey, an anonymous survey after today's session. So please try to complete this as it helps us to improve our programming. That's it. Thank you, everybody. Have a great day.